welcome to the Deep Dive. Today we're embarking on a journey into the really fascinating evolution of a critical medical procedure, liver transplantation. Medical innovation isn't always about that single aha moment, is it? Often it's, well, decades of careful refinement, constantly tweaking things to get better patient outcomes. And you've sent us some incredible source material that really maps out this journey, right, from Dr. Starzl's early pioneering work up to, the latest stuff. Okay, let's unpack this. Our mission today, to really pull out the key insights from these sources, figure out why one technique basically took over, and what that actually means for patients now.
Exactly. And what's so interesting here is seeing how seemingly kind of small changes in how surgery is done can lead to massive improvements in safety and efficiency. It really turned what was an incredibly challenging operation into something, well, much more standardized. Understanding this path isn't just about surgical history, it's about grasping that constant push in medicine to do better.
Right. So let's start at the beginning, trace it back. The first human liver transplants. That was Dr. Thomas Starzl in the 1960s. Just groundbreaking stuff back then.
Absolutely, totally uncharted territory. And the classical or conventional technique he pioneered, it involved a complete hepatectomy, removing the diseased liver, basically. But, and this is key, it also meant removing a piece of the recipient's retrohepatic inferior vena cava, the IVC. That's the big vein running behind the liver. So surgeons had to make two connections, two cavo-chival anastomoses, one connecting the donor IVC end-to-end to the recipient's IVC above the liver spot and another one below.
Wow. Okay. So disconnecting that major vein, making two separate hookups, I imagine that created some huge challenges early on. What was the biggest hurdle during that anhepatic phase, the time the liver's actually out the body?
Yeah, that was the critical time. The biggest problem was severe hemodynamic instability. Basically, the body's whole system for keeping blood pressure stable just went completely off the rails. Because clamping that IVC, you see, it stopped blood flowing back to the heart properly, the venous return. That led to big drops in blood pressure, reduced cardiac output. It was a major issue.
Okay, so they needed a fix for that. And that solution came in the mid-'80s, right? Veno-venous bypass, VVB. How did that help?
VVB was a really clever workaround, actually. It meant putting cannulas, like tubes, into veins in the leg and arm, and using a pump to bypass the blood around the clamped IVC, sending it straight back towards the heart. This kept the venous return going, maintained cardiac preload, that's the blood filling the heart, and, really importantly, kept blood flowing to the kidneys, renal perfusion. Otherwise, the kidneys could get damaged from lack of blood. It was vital, but complex.
Mm-hmm. But even with VVB helping out, this classical way still had some pretty big drawbacks that kept pushing surgeons to look for something better, didn't it?
Oh, absolutely. Even with VVB, there were still problems. Besides the risk of hemodynamic issues, you often got significant splanchnic congestion, blood pooling in the gut organs, and that meant more bleeding from the congested liver itself and these little collateral veins. So higher need for blood transfusions, often a longer anhepatic time. Plus, VVB itself wasn't risk-free. You had risks like air getting into the system, embolism, potential injury from putting the cannulas in, or issues with blood clotting, coagulopathy. It added another layer of complexity.
It's just amazing the problem solving involved. But here's where it gets really interesting. You mentioned that even with all that, the classical technique isn't totally obsolete.
Yeah.
There are still times today when surgeons choose this original method.
That's right. It still has its place. It remains the way to go in certain very specific, complex cases where you just can't save the IVC. Like if a tumor has grown into the IVC behind the liver, or if there's really extensive scarring, fibrosis, making it too dangerous to separate the liver from the vein. Also things like Chiari syndrome where the liver veins are blocked, or sometimes in really complicated retransplants with lots of old scar tissue. So yeah, it's still a crucial tool for those specific scenarios.
Okay, so that brings us to the big shift, the piggyback approach.
Yeah.
You said it was actually described way back in '68 by Calvini and Williams, but didn't really catch on widely until Sakis and his team formalized it in '89. What was the fundamental difference, the core idea that made it such a game changer?
The absolute key difference, and it was brilliant, really, is that the piggyback technique preserves the recipient's IVC. It leaves it in place. So instead of cutting out a section of that main vein, the surgeon carefully peels the diseased liver off the IVC, but the IVC itself stays intact right there behind where the liver was. Then the donor liver's suprahepatic IVC, the top part of its vena cava, is connected directly to the recipient's IVC, or sometimes to the main hepatic veins coming out of the recipient's IVC, usually side to side or like a cuff. And crucially, this usually means only one main vein connection, one anastomosis, is needed. And the donor's lower IVC stump, it just gets tied off. It simplifies the whole vascular part hugely.
So by leaving that IVC intact, what was the immediate, really dramatic benefit they saw in the operating room, especially compared to the classical way needing VVB?
The immediate massive advantage was much, much better hemodynamic stability because the IVC stayed open and blood kept flowing normally throughout the whole operation. The piggyback technique usually just got rid of the need for veno-venous bypass altogether. No more clamping the main vein, no more bypass pumps, just a much more stable patient physiologically during that critical anhepatic phase.
That's a huge difference. So where did this technique first really take hold? And what's its status now?
Well, initially it was particularly popular for kids needing transplants and for those partial grafts, like split livers or living donor grafts, because maintaining that stable blood flow was even more critical for smaller patients or when using just a piece of a liver. But today, it's become pretty much the default approach in most adult transplants from deceased donors worldwide.
Okay, so if we're summarizing the key wins for piggyback over classical, beyond just avoiding VVB, what are the main points?
Right. Well, you're looking at less digging around in that space behind the liver, the retrohepatic space. That means less bleeding, usually.
Yeah.
You also need fewer vascular clamps, which is always good, and generally a significantly shorter operating time because you've only got that one main vein connection to do. There was a study, Shoku Amiri and colleagues, they found piggyback cut the anhepatic phase time roughly in half compared to the classical method using VVB. That's a big deal in a long surgery.
Yeah, that's substantial. But like with any big change, even piggyback wasn't perfect from the get-go, right?
Sure.
What was the main challenge or potential pitfall surgeons had to figure out with this technique?
You're absolutely right. No technique is without its own potential issues. The main worry with piggyback is the possibility of hepatic venous outflow obstruction. Basically, if there's a mismatch in size or if the connection between the donor IVC cuff and the recipient vein gets kinked somehow,
Yeah.
blood can't get out of the new liver properly, it backs up, causes congestion that's called tamponade or acute Chiari syndrome, and that is a really serious life-threatening complication if it happens.
Oof, okay. So how did surgeons adapt? What sort of tweaks or refinements came along to try and prevent that outflow blockage?
Yeah, surgeons got creative. They developed modifications to make that connection more reliable and less likely to kink or narrow. For instance, there's Bill Gates' side-to-side cavo-cavostomy, which creates a wider opening between the two vena cavas, or techniques involving splitting the top part of the donor cava. It's all about ensuring a nice, wide-open pathway for blood to flow out of the new liver smoothly. Constant refinement.
Right. So let's get into the head-to-head comparison now, because there's a lot of research comparing the outcomes, isn't there? What does the data generally show?
There is a ton of data. And the big takeaway really is that piggyback techniques give equivalent patient and graft survival compared to the classical methods. So long-term, people do just as well. But piggyback offers significant advantages during and immediately after the operation, the perioperative period. Hemodynamic stability, as we said, is much better typically with piggyback because you keep the IVC open. Classical, even with VVB, carries more risk of blood pressure drops. Though, interestingly, when you look at large studies, most don't find a huge difference in the overall rates of major low blood pressure episodes during surgery or kidney problems after surgery between the two, when done well, which probably speaks to how good surgeons got at managing both techniques.
Okay, so stability is better intra-op, generally.
Mm-hmm.
What about things like blood loss?
That's where piggyback consistently shines. Studies pretty much across the board show less blood loss and fewer blood transfusions needed with the piggyback technique. People like Neri and Stieber, their research clearly showed fewer red cell units transfused and just less overall bleeding with piggyback. Operating time, as we mentioned, also generally shorter. Just one main vein connection versus two. Makes sense.
And what about complications down the line, like issues with the bile ducts? Does the caval technique affect that?
Apparently not significantly. The data suggests that the choice between classical and piggyback doesn't really impact the rates of biliary problems like leaks or strictures. Those seem to depend more on other factors, like the surgeon's skill in making the bile duct connection and the quality of the donor liver itself.
And the absolute bottom line survival.
That's the most critical point, isn't it?
Yeah.
Multiple big studies, Shiraz, Shoku Amiri, Neri, others, they all show basically equivalent graft survival and patient survival rates rates at 1 year, 3 years, 5 years. So when done by experienced teams, long-term survival is the same regardless of which technique they use.
Okay, so connecting this all up, it sounds like even though both ways can get you excellent long-term results, the piggyback method just makes the surgery itself, well, smoother and less physiologically stressful for the patient. Is that why it's become the go-to?
That's exactly it. That smoother intraoperative course is a huge plus. And yeah, in terms of what happens now, piggyback really is the default in most transplant centers. There was the big series from Miami looking at transplants from 94 to 2001, even back then. They were using piggyback in 86% of their adult cases. 86%. So VVB, that bypass machine. It's really become the exception now, not the rule. The classical technique is saved for those specific tricky situations we talked about. The tumors, the heavy scarring, bug Chiari complex redo surgeries.
And the innovation didn't stop there, right? People
Right.
kept refining the piggyback method itself. You mentioned Bill Guidi's technique and things like using ultrasound during surgery to check the graft position and flow.
Precisely. And things like modified piggyback techniques keep emerging. Plus, the rise of minimally invasive surgery like laparoscopic or robotic approaches, especially for living donor liver removal, those almost exclusively rely on the piggyback method for putting the graft in because doing it without needing bypass is pretty crucial in their settings.
So it seems like while no official body mandates one over the other surgeon judgment is still key, the practical consensus heavily favors piggyback whenever it's feasible.
Definitely. And the huge growth in split liver transplants and living donor programs worldwide has only cemented the dominance of the IBC preserving the piggyback approach because those procedures almost always use it. It really shows this balance, doesn't it? The classical method is still vital for flexibility in tough cases, but piggyback offers that streamlined physiology and reduced hassle during the operation itself.
So what's the takeaway for you listening in? It means liver transplantation has genuinely transformed. It's gone from this incredibly invasive, high-risk procedure to something much more refined, much safer. And a huge part of that leap forward is thanks to this clever evolution from the classical to the piggyback technique.
Absolutely. The classical method, still an essential tool for those really challenging cases. But the piggyback approach, it managed to combine the safety benefits of keeping that main vein open with long-term outcomes just as good as the original way. That's why it's the standard of care now.
So here's something to think about. How often does a seemingly subtle shift in how something is done, like just preserving a vein instead of removing it, completely revolutionize patient care and become the new normal? What does that tell us about that relentless drive for, I guess, elegance and efficiency in medicine, that constant refinement? Maybe consider how those ideas, innovation through adaptation, incremental improvements leading to big shifts, might apply in other fields you know about, not just surgery. Thanks so much for joining us on this deep dive into the evolution of liver transplant surgery.